Hello, everyone, again. Thank you to be here. It's David Cuervo speaking from technical support here in DES facilities in Barcelona, Europe. For us, it's a great pleasure to receive today Dr. Karatzeas from Kalamata, Greece, who will conduct this webinar about mastering everyday implant cases. Okay, as I speak before briefly, the webinar will be focusing, explaining a little bit about technical or highlights of the implant, conical built implant, one of our systems, but the more focusing will be doctor explaining clinical cases. Okay, doctor, it's your time. Again, thank you so
Let's
much
start.
for being here. Great pleasure for us. Everything is for you.
Thank you, guys. Thank you, David, for introduction. So today we will talk about the conical BLT implant. So my name is Dr. Nikolaos Karagias. I'm a doctor of dental medicine. I have my own practice in Kalamata. And a little bit about my bio. I graduated from Medical University of Sofia, dental medicine. And from 2020, I'm running my own practice. I'm a member of the Dental Association of Messina. 2023, I joined the ITI, the International Team of Implantology. And from 2025, I'm serving as a key opinion leader for this dental implants. So again, I want to thank David for this invitation. So the cases that we will speak, the clinical case that we will speak today is going to be interesting. We will see clinical cases treated with conical BLT implants. So let's talk about a little bit briefly what's a conical BLT implants and what it makes the difference and help us achieving these nice results that you will see on our clinical cases. So we're talking about an bone level implant with a conical connection, OST, which means osseointegration surface technology, which help to achieve better osseointegration, and also it's going to be a taper implant. Of course, we're talking about titanium grade 4 implants. A little bit more about conical BLT. It comes in two platforms, the narrow platform, which serves in 3.3, and the regular platform, 4.1 and 4.8. So usually I'm using, mainly I'm using the 4.1. So today you will see cases with narrow platform and a regular platform. There are available heights from 8 millimeters up to 18 millimeters. So a little bit about what you're gonna see today, and please stay tuned because that's gonna be exciting, the whole lectures. We will see surgical guides, of course. You will see cases with compromised patients and some, I will call it extreme cases because you will see immediate implantation after extracting granulation tissues. So let's start. Our first clinical case will be a narrow platform 3.3. So we will talk about a male patient, 55 years old, smoker, with a moderate oral hygiene and without any health problems. So we will talk about the two-phase surgery. The patient referred to us to treat the 25 tooth with an implant. So when this patient came to us, we, of course, immediately send him for a CBCT. And at the CBCT, we found out that there is a cyst, as you can see, on slides 90 through 100. So there is a granulation tissue, there is a periapical lesion there. I'm not gonna call it a cyst. Actually, it's a more a granulation tissue, periapical lesion. So we did the extraction in the first place. We tried to do some alveolar ridge preservation using collagen sponges. Those failed. So we rely on the secondary healing. So during the healing period, a patient experienced some purulation on this extraction site. And we were waiting 4 months until we start planning our implantation. So in the interview you will find many articles about dealing with infection sockets. There are a couple of them here that is related to my topic, so you can search it and read it if you want. So that's the
sorry, Dr. Sorry for interrupting. Yeah, just to check, because we have one attendee that's saying the screen is not moving. For us, it's working okay, but if you don't mind, any other attendees can confirm, please, in the chat that everything is going properly, and then you are able to see or to watch the slices that is moving on. Okay. Some people is working. Yeah, maybe so you have some delay with the connection and so on, because another attendee is saying that it's going well. We are watching that everything is going well, but just to be sure that if anyone is having the same problem.
Yeah, it looks like everyone can see it.
I'm so sorry. Maybe you can disconnect and connect again, and sometimes it's restarting the system, and then you'll be able to have a look. Okay. Thank you so much. I'm sorry, doctor. Sorry.
It's all right. No worries. No worries. So may I continue, please? David, we're okay, right? We can continue?
Yeah, for us it's okay. Great. Thank you.
So right now, you can see on your screens, that's the picture of the patient, that the first picture, the Protera, not Protera, we will not call it Protera, but that's the first picture that we had from this patient. So you see there is endodically treated teeth, and we will extract this one. And after 4 months, you will see a perfect healed ridge. So you will you will see a little bit about this bone, which is not so well. Let me use the pen a little bit. So everybody can see here. David?
Okay. Yeah, you're doing some red line.
Yeah, I didn't hear. Yeah. So you see here the bone, there's a small concavity. That means that we have not sufficient bone here. So we decided to open it and investigate what's going on. So here, if you see this small circle, that is a fistula. That is, as I told you before, the patient was complaining about bad smell, weird smell, and weird taste in the mouth. Was no pain or other symptoms, only this weird smell and taste. And I figured out that this small hole here was a fistula with a purulent exudate. So after opening it, we came in this situation. So here you can see granulation lesion, and we make the decision to clean and place the implants at this time. Here it's more clearly the granulation lesion, so we clean it. And at this time we're thinking about to abort the surgery or to continue, so we take the decision to continue the surgery. So we place 2 implants. We clean, of course, all the granulation tissue, irrigate with saline, and we place 2 narrow platform implants there. So how are we dealing with this big hole, this in 24 region? So what we did actually, we extend our flap distally, and we harvest some graft, autologous graft, with a scraper, and we place it on this defect here. It was looking like that. So here you can see the torque values. The torque value for in the infected side was almost 10 Newton per centimeter, and for 25 was 35, which is okay. So placing autologous bone graft here from the buccal molar area, was thinking that is enough. So we close it and we monitor. So after the surgery, the patient was looking like in the first 2 pictures. So you can see in the X-rays, the mesial implants are a little bit deviated, a little bit, because that was from the extent granulation lesion, it was a little bit hard to parallel those implants, but we fix it with Arum-based, dye-based. We will talk a little bit about that. So if you ask me if I were, what you will do today, I would say that it's better to use a guided system. So I'm going to expand a little bit about guided surgery, semi-guided surgery, and other clinical cases. That's why stay tuned. It's going to be extremely, very important and very nice clinical cases. So after 4 months, we open the lesion, we expose the implants, place two healing abutments. And as you can see in the X-rays, after 4 months, that bone was already formed. That's a fantastic X-ray. So here you can see the emergence profile using healing abutments. Very nice emergence profile. It was giving us this nice gingiva profile. Taking impression with a scan post, and we deliver 2 final zirconia crowns after 4 months. So a little bit the soft tissue needs work a little bit here. And also we use Aurum base. As you can see, the next slides, give me a second, please. So yeah, I think that's the upper right slide here. So you can see the chimney here. We managed to have these like almost in the center, not perfectly, but it's accepted. So we did that with the Aurum T base to correct it. So next clinical case, it's gonna be a clinical case using a regular platform with 4.1 implants. It's gonna be semi-guided. So here we're talking about a female, 53 years old, no smoker, moderate oral hygiene, and without any significant problems. So again, 2-phase surgery, we placed 2 regular platform implants, 10 millimeters both. And as you can see here, there are a couple of pictures. I'm gonna explain to you right now what you see here. So the first picture is a surgical guide. So everything is designed and fabricated and sterilized in my practice, in my clinic. And here you can see the guide, the surgical guide is laid on the mouth without any flap. So that means that the surgical guide is above the gums. So that's a fitting test that we see in the first image. Second image, and more experienced dentists will see some things that I will explain in a little bit. You see the implants are placed in the perfect position. Third image is going to be a little bit demonstration about how we did the semi-surgical guided. So just to mention, this system, the semi-surgical guide, we did it with the standard desk cassettes. No other cassette was used. So everything was with the stock drills that we have. That's the Protera scan that we have. So that's a 3D scan to understand the Protera in a 3D dimension. Here we should visualize the axis of the tooth that we want to restore, and then we have to start plan. So you can see that the zenith of gingiva is very low. That's very good for us because we can place the sleeves of the surgical guide of the guide very low without making implant bed. So the CBCT here show us the ideal position of how the implants should look like in this particular case. So that's a program for digital planning, not for fabricate the surgical guide. So here that's like an implant planning, the first site that we have, the first opinion that we receive. So here, if you see to have the perfect angulation, compared to other dentition and compared to the bone, it's very hard to do it freehand. Because if you see, lingually, the cortical bone is anatomically not perfectly. So there is always a choice to do freehand or guided. So in this particular case, as I told you, we did guided. A little bit about literature. You can find on the internet many articles about guided surgery. It's very predictable and accurate, and especially when surgeon is not so experienced, or there are some anatomical consideration that makes the freehand osteotomy hard and challenging, like in this particular case. So let's explain a little bit about the workflow. So I'm not gonna elaborate how we design the surgical guide. Maybe we'll do in another lecture if you agree with that, David. So here you can see the surgical guide laid on the mouth. So again, I will say that here there is no flap reflection. So this is like before made the flap. So we use ITI sleeves for the surgical guide, stock ITI sleeves, which are compatible with stock drills, as I said before. So the semi-surgical guide, so why we use it and why not like full surgical guide? So I prefer semi-surgical guide. There are many advantages for me, that's my personal opinion. So we need, in this particular case and in most of the cases, just a path, just like working path, I would say like that. So the path with the last drill, it's enough for me to finish my surgery. The other drills was do it freehand, so after like the second drill, so you're doing the pilot drill, the 2.2 drill, and then you remove it and you do freehand. So that's not a big deal for me. I'm taking the biggest of the surgical guide with the same surgical guide, but again, that's personal preferences. Other people, they like full guided. Anyways, here is the same surgical guide. So we reflect the flap. As you can see, the ridge here, the bone ridge is not very flat, so we avoid doing an implant bed here. Here's the surgical guide after finishing my osteotomies. I place the drill to visualize how the burr is inside this guide. And just to mention here that this drill, it stops here. So there is a physical stop of this drill over there. Where is my mark? So we finish our surgery freehand. After that, we place the implants with excellent torque values. You see it's 34 and 36 respectively. And here, what do you see? There is no bone, so the coronal part of this implant is exposed. So something that we should mention here about those kind of burrs that we're using here with the stock burrs with the conical BLT cassette. There is no spiral, so that very easy you can collect bone chips, bone granules here that you can see, and place it as you can collect autologous graft. In this case, I collect all those chips. I'm doing like almost of my cases. I'm collecting chips, and here I place it over there in this defect. So we was from the start known that we will have this defect. So we will, of course, I was ready to use like xenograft I had in my drawer, but it's if you can harvest autologous bone graft, that's the gold standard. And of course, you don't need a membrane, so you close the flap. Closing the flap is here. It's a tension-free closure flap with sutures. Or something very important here from the surgical aspect. Let's go a little bit back. Usually there is no release incision, so sometimes I avoid to do release incisions on my flaps. I extend my flaps more apically, distally and mesially, sorry. And that gives me the less inflammation and less post-operative pain for my patient. So let's go here, surgical phase. You can see that they are perfectly parallel in those two implants on the X-ray. That's all about this. So far we are in the surgical phase. We waiting for the prosthetic phase. Patient will come after like 1 month, I think, and going excellent. The third clinical case, which is the most was one of the most challenging clinical cases that we did so far in my practice, was placing implants, treating patients with implants that has osteoporosis, as you can see here. So you talk about a female patient, 71 years old, no smoking, she's no smoker, and with a poor oral hygiene also. That's 2 red flags for me. And we restored the 36 and 37 dentition, and also was a post-extraction site. So very quick. Again, 2-phase surgery, regular platform, 2 implants, 8 millimeters both. So first image here, you can see that you can see a bridge, a failing bridge, with a very old bridge actually. It's a failing bridge because there's, you will see later on in the x-rays what I mean. And also you can see calculus here, which is not so good habit when you start doing surgeries. Of course, we did we start with cleaning and perio, and then we went for the surgery. That's the end results. You will see this result with the final crowns, and in the middle there are the implants that is on the bone. So let's start. On the first image here, again, that's same thing in a different layout. I will mention again here, we're talking about the 2-phase surgery. So what the CBCT show us, you can see on the, that's for my digital planning actually. You'll see that there is under the bridge, the teeth that supporting this bridge are failed. There are periapical lesion. We have a small mobility also in this particular bridge. And in 112 slide that I have mentioned here, you can see that the proximity of the inferior alveolar nerve of the second premolar. So that make us to rethink about, recalculate how we're going to place those implants. Again, something very important that I have to say it again. We're talking about a compromised patient taking bisphosphonates. So that's the articles that it's that says talking about treating a patient with taking bisphosphonates with implants. You can search it online. That's the protocol for patient taking bisphosphonates that I followed. Of course, preoperative, I inform my patient about the risks and everything. So we was in contact with the physician who prescribed the bisphosphonates. And the standard, the antibiotic that we used was amoxicillin in this particular case. And of course, post-operative, we give again antibiotics and chlorhexidine and regular monitoring for bronchs. So the surgical, of course, as you know about with the patient that taking bisphosphonates, also that apply with extractions, implants, and all of these surgical intervention. Those patients, we should have a minimal trauma. So the flapless should be as long as less invasive as you can be. I mean, you cannot make like everything with magic. Of course, you need less invasive as it possible. And of course, also with the physician. So we extract the teeth. That's the failing bridge. It was a little bit hard to extract it, honestly, because we extract in partitions. The roots was broken inside on the molar. So we extract it, placing the implant, suture. That's it. Again, we extend the flap a little bit. No vertical incisions here to open the flap. Place the implants in the best prosthetic sites that you can see here. So there is extraction sites. Let me mark it a little bit because there's too much blood here. So that's the one extraction site, and the other one is here. So we placed here that we had bone. Torque values 35 and 57 for the posterior one. So that's the suture after the surgery. After surgical phase, the implants are here, so you can see how it looks like. And after 4 months, we open the we expose the implants and using healing abutments, and also there is an X-ray with the healing abutments, how it looks like. So there is no bone loss here that you can see. So another case, and I think there is no final picture. Let's go a little bit back. So the final picture, sorry about that, is this one in the middle. So we finished it with zirconia crown, zirconia bridge actually, with a T-base. So let's continue. So next case. All right. So the next clinical case will be a clinical case using a conical BLT on a 13. So we're talking about a male patient, 62 years old, a smoker, with a good oral hygiene and high blood pressure. So that's we're talking about a single implant case. So very easy to face surgery again. We make a flap, we expose, put the implant, take impression, and we deliver it. So it's the case is here a little bit. David?
Yep.
Sorry, we have some technical problems here. I have to show in a different way.
Yeah.
All right. There's some duplication. This is what I'm trying to say. So we're here. Yeah, that's from another case. It's not 4.1. Anyways.
Yeah. The left one and the middle one is okay. Yeah.
Okay. So let's talk about the 3D on this case. So that's the 3D here. So we're dealing about here, to be honest. So we put an implant after this cantilever bridge. The Protera, the patient before was like that. We open the flap, place the implant here with a low torque value 13. Take impression with a scan post, and you can see the emergence profile in the next picture. And we deliver in 4 months this crown. After the surgical phase, you can see there is you can see an X-ray of surgical phase, and after 4 months, we, as I told you before, we deliver the T-base. We deliver the zirconia crown using an angulation T-base. So something very important that we should consider here. So about this X-ray, what you see here? You see a perfect emerging profile here. The bone is perfect in this area here. And check something very interesting in the next prosthetic. That's almost not touching. This is one of the reasons why I avoid putting cantilevers in my practice. Also, there are some cases using desk lock all-on-4. So the patient here came to refer to us to put implants on the lower jaw. The bridge here was failing on the lower jaw. So we make extraction and the same day place implants, as you can see in the next picture. And using a desk lock system, in the same day we deliver a denture. After a couple of months, you can see the gums which are healed there is no inflammation, and there is a perfect gingiva color and consistency. That's all from me. So a little bit some advantage about the conical BLT that again make this clinical case successful. Again, it's going to be the OST, as I mentioned, the conical connection platform, and that makes everything super easy for me and very predictable. So that's all from me. I want to thank you. If you need anything, you can contact me through Facebook, Instagram, or mail me, and I will be happy to assist you.